So thanks ever so much for coming. Two from London and Rebecca from here in Stratford-upon-Avon. So I thought we'd just spend 20 minutes or so talking about osteoporosis, which some people might think is a bit weird because we're filming in a menopause clinic. So what's osteoporosis got to do with the menopause? And I just thought, would you have thought anything about osteoporosis, menopause? What before the last few years, when your whole life is about the menopause, what would you have thought about osteoporosis?
Well, my mum passed away from osteoporosis, not literally, but ended up with her spine crumbling away and ended up in a hospice, which ended then lots of different things happened. And she was only around 70. So the word osteoporosis has always been around me, but I never knew that it was linked with the menopause, knowing, as I've been reading all your Instagrams and your website, that the lack of estrogen has an effect on our bones and can cause osteoporosis. Now, I've only learnt that in the last 4 years.
Yes. So, and it's osteoporosis, like you're describing with your mother. It does unfortunately lead to people dying, but it's people just think, oh, you maybe fracture something and then you can carry on with your life, and it's not quite like that. And we're not all prepared for it. So we've got Professor David Reid. Thank you very much for coming. Can you just describe to us what osteoporosis is? Because people talk about brittle bone, which makes me feel a bit cross, because as we know, it's not brittle bone disease as such. Yeah. What would you describe now?
So brittle bone disease is a genetic disease which affects children, and it's called osteogenesis imperfecta. Yeah. So it's quite different from osteoporosis, but in some ways there is a similarity, because basically the bones, as women go through the menopause, every woman, and for that matter men, but the men just lose bone more slowly. Women lose bone rapidly at the menopause, and particularly in the spine, and that makes them more prone to breaking a bone. But they really lose the mineral. They don't actually lose the structure of the bone. So it looks normal. If you took it out and looked at it, it looks normal. It's just less dense, the bone, and therefore is less able to sustain or maintain the posture and maintain and is more likely to break. But instead of a break of, say, an arm or a leg, just as has happened to Meg's mum, they squash, they crumble, if you like, and the patient, the woman, gets shorter, and they can get bent. So it's probably the commonest reason for an older lady, or a lady first, if it happens early, becoming more hunchbacked, if you like. Yeah.
And so how does estrogen affect bone density?
Okay, so the major reason why women lose bone rapidly at the menopause is because they've lost their natural protection, which is estrogen, which dramatically reduces, as you know, at the menopause, and that when that happens, the bone likes to have estrogen there, and it basically doesn't like the position where it's not, so it starts turning over more rapidly and breaking down more quickly than it would normally do. And for the first few years, that rapid loss of bone continues unabated unless the woman takes HRT.
Yeah, so it's difficult. So, and certainly, Rebecca, when we talk about menopause, often we visualise older women in their 50s because the average age is 51, as we know. But then early menopause, what does that mean?
I mean, that's a huge thing actually in itself, because 1 in 100 women will be under 40 before they have when they have their menopause, so it's not that unusual, is it? No. And they're at increased risk of osteoporosis and heart disease, but osteoporosis is a huge risk because they potentially could be living without their hormones until they're 50. All women need hormones till they're 50 for their bone health, their cardiovascular health at least, and that's so important message to get out there. And actually, if you're young, you need hormones till you're 50 because there's no increased risk from treatment with HRT.
And as we know, even for older women, the benefits outweigh the risks, but certainly any young women does not need to be worried about HRT.
No risk. That's the beauty of that.
Which is really important, isn't it? And I think We know that a lot of women aren't diagnosed with early menopause. Often it can take several years before the diagnosis is made. And as David says, that bone density goes down very quickly. And that's what I really worry about these ladies' bones. And we know that HRT is licensed for the treatment of osteoporosis. Yet it's often not mentioned, is it? During guidelines, or a lot of osteoporosis experts won't think about HRT as a treatment.
Well, they did, of course, but the over the last decade or so, the relative scares, which of course are in the media, but also the regulatory authorities, MHRA, Medicines Healthcare Regulatory, have highlighted these dangers which occur in older women who are taking big doses of estrogen probably, and for that reason osteoporosis experts actually, generally speaking, don't see women anyway in their 50s and 60s, so it doesn't feature therefore as a preventative therapy of to prevent the bone loss, and to a certain extent slightly reverse it if there has
and it's the only thing that's been, am I right, that it's been proven to prevent osteopenia progress to osteoporosis?
Yes, I mean, we could have another debate about the value of the word osteopenia, but I mean that just means it's slightly low bone density, but not yet in the osteoporosis zone. So it's another debate as to whether you use that term. But you're right. I mean, it stops it prevents that loss of bone, and just say slightly increases it. So you get, if you're just on the borderline, you'll be just above the borderline for osteoporosis after a few years of HRT on average.
But I think it's interesting because the studies that you quite rightly say has scared a lot of people about HRT have been looking at giving high doses of estrogen with an older synthetic progesterone. So as we know, having estrogen through the skin as the gel or patch is safer, but also we often use this micronized progesterone, the body identical progesterone, for women who need a progesterone. And that has been shown actually to improve bone density as well. And I'm not aware that the synthetic progesterones have. And also, having this body identical HRT, as you know, there's no risk of breast cancer for the first 5 years. And after that, the risk is less. It's 10 times less than a risk a woman has if she's obese. So it's putting it into perspective.
I just love those facts. Bring them on. Listen to them all, everyone, please.
That's so important.
So Meg, you've had a scan, haven't you? We've had a few scans.
Yeah, I've had a few scans. This was my third one. So I did break my wrist, but it wasn't because I just tripped over. I fell backwards off a 3-meter wall. Okay, so that was definitely a fall. But then because of the osteoporosis when I went to my doctor, I sort of lied to get a DEXA scan because I knew that they probably would have just said no, but I was already thinking about my mum at that point. So I went for one at the Royal Free, and it came back and it sort of said I was okay. And then last October, I thought, you know what, I'm just want to have another look at it because it's still in the back of my mind because my mum had really, I watched her, for a couple of years being in a lot of agony and, bedridden because of the spine completely crumbling away, and, and I just, kept reading that it was hereditary and this and that, but I was also told that being on HRT was fine. So I was on the estrogel, the body identical, and I've been on it now for about 5 years. And so last October I did go back and I had another DEXA scan done at the Shard, but this time it said I had a 30% chance in my left hip, I think they said, of a breakage. So then I started to panic a bit. I was a bit like, oh my God, because I am on HRT. So I've just done another one today with David, and it was looking okay-ish, shall we say, for now. But we haven't really done a proper reading, but we did it today. It was great, ladies. It's painless. You just lie on this mattress. It's nothing like...
Very open, isn't it?
It's open. You're not like an MRI or anything like that. It's very comfortable. You lie on a really soft mattress, and, it just goes up and down, and you've got your clothes on. I went in the room saying, am I going to be naked in front of David and everyone? And they were like, no. Shit. And then they were like, and then it was done, and it was just quick and easy, and probably took less than 10-15 minutes. And also I just want to point out that having this DEXA scan, that they made me do this plough position, ladies, and I've had 2 which have not made me do that position. So they've just made me put my legs up like on a sponge, so it's in a T shape, so my spine was completely flat. They just turned my ankles in a little bit, but this one that was done today was a lot more thorough by actually really doing the snow plough and pushing my hips right down.
Very interesting, because there are very few DEXA scans available in the NHS, and because osteoporosis is so common, some reports say as many as 1 in 2 postmenopausal women have osteoporosis, but yet we can't, as GPs, often it's really hard to refer people for a DEXA scan. I've had a couple of scans in London, and I literally lay there. I just said, lie down, lay there, done, and off I was, and they printed off a report and gave it to me. So, you know, I think if women are going to have a DEXA scan, they have to be really careful who's analysing it, because it's all about positioning the patient, isn't it?
It really is, partly, and also that we were able to, with Meg today, because her mum had had spine fractures, we were able to get her lie on her side, took another 5 minutes, and we had a look at the spine, which is fine and didn't show any fractures. But it's that's an additional way of which we can detect, and also it helps you to analyse the spine from the front as well. Yeah. But so there are 2 elements that are important. One is that it's done correctly, and you know, the Osteoporosis Society, for example, have a course for people to go on to learn how to do the scans properly, and to start the analysis process. And so many people, certainly in the private sector, have never been on those courses. So the quality of the scans is, I see quite a lot, are not always as good as you would like. And then it's important that those scans are interpreted by somebody who knows what you're looking for. And so, for example, you don't mind me saying, there were 2 of the bones in your back, there were 2 bones that were quite low, not dramatically, but you know, were all right, but 2 that were quite high. So you have to exclude those 2 that are high from the overall measurement, otherwise you're giving patient false reassurance in some ways.
So that's why it's so important.
So it's really important that somebody looks at it, that's used to looking at it, and that gives a clinical interpretation of the scan.
Which is really important. And because I know you do some amazing work with the Royal Osteoporosis Society, isn't it? It was the national. And is there any move to have more DEXA scans available in the NHS, do you think?
There are quite a lot, but then they're all pretty busy, and because although there are many people who say, oh, I would like to get it. So, for example, your mum has clearly had osteoporosis, even though she might not have had a DEXA scan, but she had the result of osteoporosis. But because it was her spine, that doesn't count as a risk factor for a DEXA scan in the NHS, because it's not. So you got one because you said I lied.
I said I tripped.
That's all right, but you did trip.
I did trip,
3 meters over, that's all right. You tripped. So, but if you've said you've had a fracture, then you'll get one. Or if you say you've lost,
picking women up before they have their fracture.
Well, ideally, of course, but that's not where the NHS and where service provision lies yet. It's the primary aim is getting people who've had a fracture, but you know, ideally, of course, because by the time most women have had a fracture, they're actually beyond the stage probably where conventionally you would get HRT.
Well, this is the thing, we really want to capture women for lots of education purposes and health, preventative purposes, who are perimenopausal, so the time before the menopause. Yes. And so for women who have an early menopause, like you say, under the age of 40, 1 in 100, one under the age of 30, 1 in 1,000, there's a lot of women in their 20s, 30s out there who are perimenopausal. Yes. And a lot of these women are being turned away, saying you're too young to be menopausal, it won't be that. Yeah. And actually, these are the women that really need scanning. And if you talk to them, they've often got a family history of early menopause as well.
One point to get over, because people are worried about radiation as well, and how low the radiation. Even I was quite surprised.
Yeah, everyone was in the room today, weren't they? So it's not running out.
Right, David?
Yeah, well, it doesn't matter if I'm irradiated at my age, but for most people, yes. So you have to be, the operators have to be away from the scanner by a metre, but actually there's very little scatter around the scanner. The scanner just technically has a very high radiation dose, but only to that very significant point that you're hitting at a point. And overall, the dose is about of one scan is about the background radiation that you'll get walking about the streets. It's far less than flying to America, for example. So, and way less than 1/10 of a chest X-ray. So you wouldn't want to have one every day, but doing one every year is may not be clinically valuable, but it's absolutely no danger of it from the radiation perspective. So it's a tiny dose.
So we've talked obviously about HRT, but what else should we be doing to protect our bones, but also keep our bone health optimal?
Yes, I mean the evidence base is not for very extensive dietary manipulation and so on, because the evidence base currently is calcium, a moderate amount, not a huge amount, because I think you said it's not good for your arteries. So you need a moderate amount. You need vitamin D, and that's a major issue.
Everyone should be taking vitamin D.
Well, to be sure, they should be taking it. Certainly in the winter months, it's probably wise to take a supplement, even in this wonderfully sunny part of the UK as opposed to the north of Scotland. But it's useful in the winter months to be sure that you're getting enough, but you can get enough under the skin, and you build some up over the summer just by being outside and getting fresh. But to be safe.
So vitamin D.
800 international units a day is more than enough.
You can just buy that, can't you, in boots?
You can buy it in boots, and
liquid form.
Spray. Some people have
and the other thing which you practice in spades is weight bearing exercise. That's really important.
Just explain what's weight bearing exercise.
So, what I do is, we have all these fads, and really it's just gone back to good old fashioned Arnold Schwarzenegger, just lifting weights. Like we all pay for these new things and these new fads, Soul Cycle, Barry's Boot Camp. There's all these things going on, but really you just need old fashioned weights. And just doing like lunges, squats, deadlifts, all of those things which everyone can do, and you can do it anywhere, any gym. You don't have to be paying any fancy money to go to a gym. My gym's £35 a month, and you just, as long as it's got weights, and then you can just do weight bearing. And then I've started doing couch to 5k.
Have you? Good.
Doing that just because I wanted to shock my joints a bit more, because it's not a lot of running. I'm not going to run half of a marathon or a marathon, but it's only 30 minutes, and it's just good for cardiovascular, as we know also. But I think we need to also point out to all the ladies out there about their alcohol input, because I think most of the women I know, and most of the women that I know, drink way over the amount of units of alcohol, and this is going to have an effect, isn't it, on their bones as well as their heart. We know that. So I think, and smoking, we should point out as well.
They know about smoking, they know about family history. Everyone is, or a lot of people know about calcium in their diet.
But
you're right, I think people don't think about drinking, do they?
So a little bit of alcohol is probably quite good. But when you get over 2 or 3 units a day,
which is easily done.
Which is very easily done, because you go into a pub now and say I'll have a glass of wine, and they give you 250 mils. Well, that's your 3 units all at once.
Work to affect our bones.
Well, it's complex, but it has, alcohol has a direct suppressant effect, not on the bone breakdown, but on the bone building side of the bone. So it inhibits. So you might be doing all these pounding the streets to build up to encourage the osteoblasts to lay down new bone, and at the same time you're discouraging them from doing anything because you're taking too much alcohol. So they're confused. So it's partly that, and it's obviously a very long period of time. You don't get it just by having a binge.
No, but it's important that we know, isn't it? Because I think a lot of our work educating women is about them making right choices, but they have to be given the right information, and then they can have the right choices for them. And we don't want it to be too late. We want to.
No, it's all about prevention.
Is key. So well, thank you. I think
there was one thing maybe just about the exercise, because we don't know how to build bone in the spine. We really don't know how to do it. It seems a good idea to do spinal type running, but running is really good for your hips.
But not this.
It doesn't actually give you much, because there's an expression, and I used to say it when I go to Leeds. There's a thing in Scotland: never shove your granny off a bus. Off a bus, right?
Never heard of that.
And I said, well, actually, shoving your granny off a bus might be quite good, because she would land on her bottom, and that gives her a bit of stress on her bottom. But it's actually quite difficult if you think about it. How do you stress your spine?
Yeah,
you're not
not
bouncing up and down. So we don't really know. And the best you can probably do is to do bodybuilding, body balance, or Pilates. Pilates is probably about as good, but we don't know that really makes a difference.
Yeah, my dad does Pilates 3 times a week, and he's sworn and he's always had a bad back, and he's been doing it now. He's 78 and he's been doing it, and it's really worked for him.
Even if it doesn't actually strengthen the
Your
bone,
core
it keeps
is
them
amazing.
cool,
Yeah.
keeps the back erect.
But But I think any exercise often is good. It's finding something that works for you. No, that's been really useful. So thank you ever so much. I hope that's been informative to other people. So thanks ever so much for your time. Thank you.
Thank you.